we do not yet have a cure for ADPKD. That is, we don't have a means to prevent cyst formation, and we do not yet have treatment options that directly shrink cyst size. So we will spend the majority of our time on this idea of targeting progression or preventing progression. Hi, I'm Judith Maddatu, and I'm a nephrologist from Indiana University. Welcome to this webcast from the PKD Foundation on shared decision-making in ADP. This is a three-part series where we will discuss the principles of shared decision-making and their importance in managing ADPKD. We will review the available treatment options. Lastly, we will go through tips on advocating for yourself and collaborating with your healthcare providers through shared decision-making. You've reached part 2. With autosomal dominant polycystic kidney disease, we know that it's a rare genetic kidney disorder in which fluid-filled cysts develop in the kidneys, leading to kidney failure. It's important to note that ADPKD is different in inheritance pattern compared to autosomal recessive polycystic kidney disease, which is an even rarer genetic kidney disorder that's also characterized by cysts in the kidneys, but is typically diagnosed earlier in children. There are also other disorders that cause cysts within the kidneys for which treatment will not be covered in this series, but it's important to know that they exist. When it comes to treatment for ADPKD, let's talk about what's available. I think it's helpful to consider 4 main categories when we think and address treatment. As full disclosure, these treatment options are not exhaustive, but this is meant to be a brief overview. My hope is that this initial knowledge can spark more in-depth discussions with you and your healthcare providers. In addition, treatment options discussed in the following slides are centered around kidney function, although we will briefly discuss non-renal, non-kidney manifestations. So at the time of this recording in 2023, we do not yet have a cure for ADPKD. That is, we don't have a means to prevent cyst formation, and we do not yet have treatment options that directly shrink cyst size. So we will spend the majority of our time on this idea of targeting progression or preventing progression. As chronic kidney disease worsens, we are left with renal replacement therapy and the options of dialysis or transplant. And as we know that PKD is a systemic disease, meaning it affects other areas of the body, we will touch on prevention of sequelae or treatment of these other areas as the last part of considerations for treatment. I do want to mention that we'll be focusing on treatment that is readily available to you. So there are ongoing clinical trials for PKD, but we will not be discussing those study drugs in this session. Let's back up a step and consider how we assess progression of kidney disease in ADPKD. Firstly, we monitor and evaluate kidney function through blood work. Creatinine is a muscle metabolite measured within the bloodstream, and it serves as a marker of inflammation of filtration. The higher the creatinine, the worse the kidney function. We use this creatinine value and plug it into an equation called CKD epi and derive something called eGFR, or estimated glomerular filtration rate, as shown in the panel on the left. GFR shows how well the kidneys are filtering. As you can see, through stage 1, a GFR of 90 or more is considered normal, whereas GFR below 15 is considered chronic kidney disease stage 5, and it is the stage where most people are considered for dialysis. It's important to remember that creatinine and this GFR can be affected by things like diet and muscle mass. And we often do see fluctuations in the setting of infection, acute illness, or fluctuations in blood pressure. One creatinine or GFR value should be considered in the context of your prior labs. That is, we use multiple labs as a trend to best consider what stage of kidney disease you actually have. Aside from blood work, we also use something called total kidney volume, or height-adjusted total kidney volume, to assess risk of progression to PKD. As you can see on the picture on the right, we're trying to obtain 2 different measurements of the kidney width as well as the depth. We use these measurements and plug it into the ellipsoid equation to measure your total kidney volume. Through the CHRIS study done in 2006, we found that kidney enlargement resulting from the expansion of cysts in patients with ADPKD is continuous. So you can see on the panel on the left, kidney volume and cyst volume increased as we get older. Furthermore, there is an association with the expansion of cysts and decline in kidney function. And we can see this on the graph on the right, in which total kidney volume denoted by the blue line is increasing, and we see a subsequent decrease in kidney function through GFR by the red line. Higher rates of kidney enlargement are associated with a more rapid decrease in kidney function. And from this study, we now understand that the progression of kidney disease in ADPKD came alongside the expanded growth of cysts within the kidney. The Mayo Clinic derived a risk classification based on this total kidney volume measurement. And you can see in this table, we've got 5 classes of ADPKD, class 1A through 1E. And through further evaluation, we denoted that patients with Mayo Classification 1C, 1D, and 1E are at higher risk of progression of their kidney disease. And you can see how it's correlated with the total kidney volume. So, what are our tools at targeting or slowing the progression of kidney disease in ADPKD? 3 main considerations would be blood pressure control, diet, and tolvaptan. As far as blood pressure control, from previous studies, we know that blood pressure control is important in the maintenance of PKD. However, we considered how strict of blood pressure control do we actually need with the HALT study that took place from 2006 to 2014. We looked at standard blood pressure control defined as systolic blood pressure between 120 to 130. We looked at standard and diastolic less than 80 versus low blood pressure defined as systolic target of 95 to 110 and diastolic of 60 to 75. As further subcategories, we looked at the use of lisinopril, a type of ACE inhibitor for blood pressure, alongside placebo, compared to lisinopril and telmisartan, an angiotensin receptor blocker, or ARB in combination. We found that the lower blood pressure target did correlate with a slower kidney volume growth, but this did not translate to a difference in kidney function. However, we did see favorable changes as far as heart muscle effects, this lower left ventricular mass, so less stress on the heart because of high blood pressures. And we saw comparatively less protein in the urine, which is also important to know, as having protein in the urine can be a sign of ongoing kidney damage. So when it comes to your blood pressure control, it is important to partner with your physician to discuss what would be optimal based on your other health history and to discuss any side effects you may be experiencing with your blood pressure medications. Because of this HALT study, I would say we tend to use ACE inhibitors and their ARBs for blood pressure control in ADPKD, but not everyone is able to tolerate these medications. So it's important for us to tailor your blood pressure medication accordingly. For dietary considerations, we will touch on water and salt intake and briefly on general diet. The study done in 2022 looked at salt intake versus protein intake in ADPKD in followed patients over 4 years. They found that salt and not protein intake was associated with kidney function decline. This was through findings of elevated copeptin levels that were measured in the bloodstream. Copeptin is a precursor to the hormone vasopressin, an antidiuretic hormone that's typically increased in response to low blood volume or increased osmolality or solutes, such as sodium, within the bloodstream. Thus, the results of the study suggested that salt intake may have detrimental effects by increasing vasopressin, and through this, we saw a decrease in eGFR, so a higher rate of kidney function decline. Similarly, with water intake, water can suppress vasopressin levels. And so avoiding dehydration is a general recommendation to this effect. Your provider may not necessarily prescribe a set amount of water intake, but with the risk of urinary tract infections and kidney stones, water intake from 2 to 3 liters is generally considered adequate. As far as other dietary considerations, there is some data looking at keto diet, water fasting, or intermittent fasting, and they've shown some good things as far as polycystic kidney disease. There isn't any set recommendation for these yet because we understand that there are other kind of health conditions that need to be taken into consideration. Therefore, I would suggest you partner with your provider as well as your dietitian to look at what specific diet would be best for you. So for now, we only have one FDA-approved medication that slows cyst growth called tolvaptan. The brand name is Gynark. This medication requires REMS, or risk evaluation and mitigation strategies monitoring, because it carries a black box warning for liver toxicity. Based on your kidney disease and evaluation of your risk of progression, so your blood work and your total kidney volume, your nephrology provider may suggest this particular medication as a means to slow progression. Under the REMS monitoring program, you would be required to have liver function tests drawn at baseline, 2 weeks, and every month for about 1.5 years, and then every 3 months for however long you're on the medication. There were a few pivotal studies on this medication, the Tempo 3444 studies, as well as Reprise. And you can see the results from the Tempo 34 here, where you can see how tolvaptan in blue compared to placebo in red slowed the increase in total kidney volume. And we also did see a slower decrease in kidney function decline compared to placebo on this bottom panel. Okay, so as kidney disease progresses, your providers may start to discuss other areas of what is considered comprehensive chronic kidney disease care. This may include discussions on controlling anemia. The kidneys play an important role in red blood cell production, and treating anemia has shown to help slow chronic kidney disease progression as a whole. Similarly, maintaining acid-base balance is also important and has been shown to slow chronic kidney disease progression. So your providers may discuss bicarbonate levels and options to improve them, either through diet or medications. Lastly, the kidneys are involved in maintaining bone health. So your nephrology providers may bring up supplementations for vitamin D and controlling levels of parathyroid hormone. With PKD, there are other areas of the body that can be affected by this genetic disease. Depending on your history, your provider may suggest treatment to prevent issues in other organs. For instance, having PKD puts you at risk for developing kidney stones and having urinary tract infections. It may be important to partner with your urologist or your infectious disease specialist on how best to treat these. PKD is also associated with heart valve abnormalities, vessel abnormalities such as aneurysms, and it's important to know your risks and do the appropriate screening for these. Similarly, due to the nature of cyst formation, PKD is associated with development of renal cell carcinoma, and having images, if there are concerns on them, would be important to have follow-up images and close monitoring of those. PKD is also associated with development of diverticuli or hernias, and so if you're having some of these issues, it's important to partner with your gastroenterologist to figure out how best to treat, bouts of inflammation, or if you need to have surgeries to correct those hernias. When kidney function falls toward stage 5 or end-stage kidney disease, you and your providers may need to discuss next steps. This may include consideration of dialysis. So dialysis is a tool we use when the kidneys no longer function. Dialysis does not heal the kidneys, but is considered a life-supporting measure when the kidneys don't work. Dialysis is meant to filter the blood of toxins, extra fluid, and extra electrolytes so that these components do not build up in the bloodstream and become life-threatening. Dialysis can take multiple forms. In the clinic, we can provide hemodialysis or blood dialysis, which typically occurs at a minimum of 3 times per week and on average 4-hour sessions. We access your bloodstream through a catheter or surgically made blood access called a fistula or graft. Dialysis can also be done at home. You can do the same blood dialysis at home on a similar machine that is in clinic. There's also the option for peritoneal dialysis, which uses your abdominal membrane, the peritoneum, as a filter. And we use dextrose-containing solution to clean your blood. The solution is instilled either manually or using a machine called a cycler, either throughout the day or over several hours at night. And multiple exchanges of the fluid help achieve the cleaning we need. If you are at high risk of kidney disease progression, or you've been told you have advanced kidney disease, I would encourage you to consider your dialysis options early on and to partner with your provider on what options is best for you. Transplant is also the mainstay for when someone reaches end-stage kidney disease. Similar to dialysis, I would encourage you to think about the possibility of transplant and to discuss options for living donation over deceased donation kidneys. It's important that you talk with your family and friends about your journey with PKD and your need for a transplant. It's beneficial to know your options early, and if you have someone who's willing to donate their kidney, there are several advantages. A genetic link between the donor and the recipient is no longer required for a successful transplant. You don't even need to have the same blood type as your potential donor to get a kidney, because there now exists internal paired exchange programs within transplant centers and a national paired exchange program that allows incompatible pairs to match up with another incompatible pair. This allows two donors to switch recipients. In summary, in the second session of shared decision-making, we discussed how we evaluate kidney disease and consider risk of progression using blood work and measuring total kidney volume. We had a brief overview of the treatment to slow progression through blood pressure control, dietary considerations, and tolvaptan. As kidney disease progresses, it's important to consider your options when it comes to renal replacement therapy through dialysis or transplant. Thanks for listening. Please join us for part 3, where we will discuss tips on collaborating with your providers through shared decision-making.